With this, I like to invite Dr. Parthopratim MAJUMDER, who is from Shankar Nethralaya, Chennai. He is a senior consultant, very experienced in a lot of experience in uveitis and scleritis, retinal vasculitis, prolific writer. So he will be talking on anterior uveitis. Don't think so simple. Partho, please.
Good morning, all. Thanks, sir, for including me in this instruction board. It's not working out. So if you see that there are several studies, most of them are retrospective and were published from the tertiary eye care hospital. So though you don't get the exact profile of the anterior uveitis from the rural or community setting, but still this gives you an idea that how the pattern of uveitis is in India. So if you see the demographic profile of the patients of anterior uveitis, most of these studies have showed that anterior uveitis is the most common subtypes of uveitis. 35 to 57% of all cases of uveitis are anterior uveitis, mainly the male predominantly involved. And the age range affected are 19 to 16 years, mostly they are unilateral. And acute non-granulomatous anterior uveitis remains the most common clinical presentation of this anterior uveitic cases. Now, if you go to the idiopathic causes of anterior uveitis, most of them remain idiopathic, though this number has come down with this recent studies. And the HLA-B27 remains the most common cause of identifiable anterior uveitis, followed by tuberculosis, viral Fuchs uveitis, and sarcoidosis. I'll be showing few case scenario which will help you to understand why we have kept the title anterior uveitis is not so easy. Now, sometimes it's required that you need to spot the zebra in that heart, because it's very important to understand that there may be an uncommon presentation of common anterior uveitis. So one such entity is the HLA-B27 uveitis. All of you know that it predominantly affect the young male, recurrent in nature, and characterized by the pain, redness, photophobia, with a high fibrin content in anterior chamber and hypopyon. Now, I'll show you a case here, a 23-year-old presented with ocular pain and diminution of vision for 10 days and diagnosed elsewhere as endogenous endophthalmitis. So, why endogenous endophthalmitis? There was severe anterior chamber reaction and severe vitreitis. So, the patient was advised vitrectomy, and the patient, when we took the history, patient gave us the history of similar attacks of redness and eye pain in the past, and documentation showed that he was earlier treated with topical steroid and cycloplegic. So we did send the patient for urine culture and blood culture, which were negative. All laboratory workup was negative, but HLA-B27 was positive. So we treated these patients aggressively with IVMP and high dose of oral steroid, followed by and also methotrexate. And you can see the response in these patients that vitreitis and anterior chamber cleared completely. So you need to understand a very rare subtype and which only affects only less than 4% maybe. So because this is a study we did from Shankar Nethralaya, which included 255 cases of HLA-B27, and you can see here the 4% of the cases can present with anterior and intermediate uveitis, which has been earlier described in Sun classification, that inflammation is so severe in anterior chamber and also in vitreous that you cannot classify them either as anterior or intermediate, so better you use the term. So that was kept at that time. So this is a sequelae of a similar case who actually underwent vitrectomy elsewhere. You can see a 28-year-old female, the suspicion of endogenous endophthalmitis. Vitrectomy was very successful, but the patient ultimately developed phthisis. So this patient was also HLA-B27 positive with history of recurrences. This is another case of HLA-B27 uveitis you can see here, and you see the patient actually presented with exudative RD and finally treated with IVMP. So sometimes this kind of common identifiable case of uveitis can present with some different. These are the paper which has highlighted that the atypical presentation of HLA-B27. Now, sometimes you need to understand that the changing face of anterior uveitis, which can actually present in various other form, there are maybe overlap of granulomatous and non-granulomatous phenotype. For classical example is sarcoid, which can present as sometimes as a granulomatous uveitis and rarely can present also as a non-granulomatous. And then various systemic disease can initially present as a anterior uveitis, so that you have to come. So sometimes you need to understand that there may be anterior uveitis may be overlooked, so you need to spot the cat in the shadow, so which is very important. And one more such entity is that Fuchs uveitis, which you can actually we can term it as a most underdiagnosed and overtreated cases of uveitis. Another such entity is that tubulointerstitial nephritis and uveitis. It's a very rare entity. Only 3 reports has been published from India and 2 are from nephrology perspective. So if you see that the main reason for that is that heterogeneity of the clinical phenotype of this inflammation, and chances are there that when the patient present to the ophthalmologist, the renal parameter may be in well controlled and normal limit, and maybe we are actually leveling them as an idiopathic anterior uveitis without investigating further. So you need to have a high index of suspicion and actually try to investigate these children also with for this entity. Now, sometimes you need to understand that the anterior uveitis can come as a sheep's clothing and pick up the uncommon presentation of common anterior uveitis, which can be very dangerous. And one such entity is GIA, juvenile idiopathic arthritis. They come as a benign. The child will present with a white eye without any congestion, and relatively they are asymptomatic, and sadly most of the time they present to us when they developed a complication, either the cataract or the secondary glaucoma. With that they will present to the ophthalmologist. They are usually associated with band-shaped keratopathy, bilateral in nature, and the runs a chronic course, and an ophthalmologist usually keeps on treating them with topical steroid, which further adds to the problem of the child. So you have to be very, very careful in treating any anterior uveitis until and unless you actually rule out a GIA. Now, 5 tips for managing GIA. Always rule out GIA before managing any case of uveitis. Inquire about joint pain, especially the knee joint. Review with a rheumatologist, which is very important. And you have to understand that these are the children, they need the systemic therapy, not the local therapy. So don't treat them with a topical corticosteroid alone. And monitor the vision in every visit. IOP recording is very important in these children. I know it is sometimes difficult to record IOP, but don't actually miss that. And fundus examination in any case of anterior uveitis is must. So this is another granulomatous uveitis in a 5-year-old child. You can see that it's maybe you would have started the topical steroid and all, but if you see that UVM picked up some seed-like echoes more inferiorly, and every investigation was within normal limit, and anterior chamber tap actually revealed malignant cells, and this was a case of diffuse anterior infiltrating retinoblastoma. You look at the location of the tumor cell seeding, and you can make out that sometimes this seed can come to the anterior chamber, mimicking a case of granulomatous anterior uveitis. So be careful. And just last case of my talk is a 6-year-old female child, again with a known case of leukemia and remission, and you can see presented with a hypopion-like picture. And when this aqueous was collected and immunophenotyping was done, these were the actually blast cells. So these are not the inflammatory cells, these are the collection of the malignant cell which can mimic the anterior chamber. To conclude, do not take anterior chamber as an easy one and treat empirically. Always you need to make a diagnosis. One should not always wait for 3 attacks of non-granulomatous anterior uveitis to investigate. Sometimes you may require to investigate these cases also. All cases needs thorough extensive evaluation before leveling them idiopathic. Thank you.